Recording.
Hello, my name is Amy Mikahiel, and I'm a second year MAT student. The topic I chose from Gen Med 2 was breast cancer. I chose this topic because my mom was diagnosed in 2012 when I was in seventh grade. I remember being so young and not understanding what was happening, so I wanted to fully understand what was going on to my mom physiologically 10 years ago. This is an overview of everything I will be covering, an introduction to the topic, the symptoms associated with breast cancer, the diagnosis, as well as the anatomy and physiology of breast cancer, treatment plans, the conclusion, and then my references. First and foremost, we need to understand what breast cancer is. Breast cancer is a disease where malignant cells form in the tissues of the breast. There are several statistics about breast cancer that explain the prevalence and just how common the disease is. It is estimated that 1 in every 8 women will be diagnosed. Every 2 minutes, a woman is diagnosed with breast cancer in the US, and it is the most common cancer among women worldwide. This graphic shows how breast cancer encompasses the entire globe, with there being so much pink everywhere, breast cancer being the leading, followed by cervical cancer, and then non-melanoma skin cancer, thyroid, and then liver. The following is a list of common signs and symptoms associated with breast cancer: nipple tenderness, a lump near the breast or in the underarm, changes in skin texture, and enlargement of pores. These are more signs and symptoms of breast cancer, so an unexplained change in size or shape, an unexplained swelling or shrinkage, especially if it is on one side, and then nipple discharge, and the two different types are serous and sanguineous. Serous is when the discharge from the nipple is watery, while sanguineous is when the discharge from the nipple is bloody. Some potential differential diagnosis for breast cancer is breast lymphoma, which is a rare form of non-Hodgkin lymphoma, angiosarcoma, which is a rare cancer that develops in the inner lining of the blood vessels and lymph vessels, and myofibroblastoma, which is a benign tumor occurring mainly in menopausal older women, typically aged about 55 or older. In this slide, we have the anatomy of the breast. The areola and nipple are on the outside, while the lymph nodes are on the inside. The lymph nodes are small bean-shaped structures that filter lymph and store white blood cells. The most common tumors will grow in the upper outer quadrant, while the lowest frequency of tumors will grow in the lower inner quadrant. So as you can see, there's muscle in the anatomy of the female breast. There's also the chest wall, and it is mainly composed of fatty tissue with lobes, ducts, and lobules. In this slide, we go through the pathophysiology behind the development of breast cancer. In DNA strands, there are procancerous genes called BRCA1 and BRCA2. Due to DNA damage and genetic mutations, there can be an inheritance of DNA defects due to the influenced exposure to estrogen. There are several different ways to diagnose breast cancer. It can be through a breast ultrasound, a diagnostic mammogram, a breast MRI, and a biopsy. The first one is the breast ultrasound, which is a machine that uses sound waves to make sonograms of the inside of the breast. Diagnostic mammogram is a more detailed X-ray of the breast. A breast magnetic resonance imaging is a body scan that will take detailed pictures of areas in the breast. And finally, biopsies are tests that remove tissues or fluid from the breast under a microscope to observe. In order to understand the best course of action, it is important to recognize that each stage has a different route. Stage 0 is also known as in situ carcinoma, which means the cancer stays in place. The three types are DCIS, which is ductal carcinoma in situ, lobular carcinoma in situ, or LCIS, and Paget's disease of the nipple. Ductal carcinoma in situ is a non-invasive cancer where abnormal cells have been found in the lining of the breast milk duct. In stage 0 breast cancer, the atypical cells have not spread outside of the ducts or lobules into the surrounding breast tissue. Ductal carcinoma in situ is a very early cancer that is highly treatable, but if it's left untreated or undetected, it can spread into the surrounding breast tissue. The next one being LCIS, or lobular carcinoma in situ at stage 0, is generally not considered a cancer. Although it has carcinoma in the name, it really describes a growth of abnormal but non-invasive cells forming in the lobules. Lobular carcinoma may indicate a woman has an increased risk of developing breast cancer. The best treatment route for stage 0 is tamoxifen, which is hormone therapy that we will be discussing in further slides. The next stage is stage 1, and stage 1 is when the cancer is contained only to the area where abnormal cells are. The breast cancer has been detected in early stages and can be very effectively treated. It can be divided into 1A and 1B and is dependent on the size of the tumor and the lymph nodes. The best treatment route is surgery and/or radiation. The next stage is stage 2, which means that the cancer is growing but is still contained. Typical treatment for stage 2 is chemotherapy, radiation, and surgery. The differences between stages 2A and 2B is the size of the tumor and whether the cancer has spread to the lymph nodes or not. The next stage is stage 3. Stage 3 means the cancer has extended beyond the region of the tumor and has invaded nearby lymph nodes and organs. It has not spread to the other organs. The treatment for stage 3 is a mastectomy, radiation, hormone therapy, or chemotherapy. The difference between stages 3A, B, and C is the size of the tumor and whether the cancer has spread to lymph nodes and surrounding tissue. Stage 4 means the cancer has spread to other areas of the body, such as the brain, bones, lungs, and liver. This is a very highly invasive cancer. Unfortunately, this is not curable, but it is treatable, and through excellent care, treatment can extend life. The most common form of treatment is surgery, and it comes in the following forms: lumpectomy, mastectomy, breast reconstruction, and lymph node removal and lymphedema. A lumpectomy usually removes the least amount of breast tissue needed to get the tumor out and some of healthy tissue that surrounds it. A mastectomy is the removal of some or all of the breast. Breast reconstruction is a different option to reconstruct the breast tumor post-surgery. Lymph node removal and lymphedema is the possibility of removing lymph nodes to examine and determine if it has spread or not. Another form of treatment is radiation. Radiation uses high energy rays to kill cancer cells. It can also be used to destroy any remaining mutated cells that remain after surgery. So whenever my mom had a lumpectomy, right after that, she began radiation. And so typical radiation therapy is about 5 to 6 weeks. Another one is hormone therapy. The most common form of hormone therapy is through the use of the drug tamoxifen, as we mentioned previously. Tamoxifen blocks estrogen-shaped openings in the cells and can be taken as a pill every day for up to 5 years after surgery. The most common one that we've all heard of is chemotherapy. Chemotherapy is a systemic therapy where the drugs travel in the bloodstream. It is also a combination of drugs that either destroy cancer cells or slow down the growth of cancer cells. A typical course of chemotherapy is about 3 to 6 months, and this typically happens in the beginning of the cancer process. So there are doctor visits, mammograms, pelvic exams, and bone density that would be potentially done after somebody has completed their cancer treatments. So ongoing treatment of somebody who was diagnosed with breast cancer would be frequent follow-up doctor visits if you have finished treatments. Your follow-up visits will probably be every few months at first. The longer you have been free of cancer, the less often the appointments are needed. After 5 years, they are typically done about once a year. Next is mammograms. If you have had a lumpectomy or partial mastectomy, you will probably have a mammogram about 6 to 12 months after surgery and radiation are completed, and then at least every year after that. Women who've had a mastectomy typically no longer need mammograms on that side. But unless you've had both breasts removed, you still need to have yearly mammograms on the remaining breast. The next is pelvic exams, and these are necessary if you are taking either of the hormone drugs, tamoxifen or toramifene, and still have your uterus. Your doctor will likely recommend pelvic exams every year because these drugs can increase your risk of uterine cancer. This risk is highest in women who have gone through menopause. Next is bone density, and bone density is also important because if you are taking a hormone drug such as anastrozole, letrozole, or exemestane for early stage breast cancer, or if treatment puts you into menopause, your doctor will want to monitor your bone health and may consider testing your bone density. And finally, there are many other tests that may be necessary, such as blood work, imaging such as bone scans, x-rays, CT or PET scans, and these are not a standard part of a follow-up for most women who've been treated for breast cancer because they haven't been shown to help them live longer. But one or more of these tests might be done if you have symptoms or physical exam findings that suggest that the cancer might have come back. There are some genetic and environmental factors that would lead someone to having a higher predisposition to breast cancer. Genetic ones would be gender, age, race, obesity, family history and genetic factors, personal health history, menstrual and reproductive history, certain genome changes, and dense breast tissue. Breast cancer in women is more common than breast cancer in men. The age of breast cancer in women becomes more invasive after the age of 55. Race prevalence in breast cancer is higher in Caucasian women than women of other races. Obesity is a risk factor for both men and women. Menstrual and reproductive history, when there is menstruation, late menopause, having your first child at an older age, or never having given birth are all ways that can increase your risk. Certain genome changes, such as BRCA1 and BRCA2, and having dense breast tissue can increase your risk because it can make detecting lumps harder. Some environmental factors are lack of physical activity, poor diet, being overweight or obese, drinking alcohol, radiation to the chest, and combined hormone replacement therapy. Some long-term effects of breast cancer are anatomic changes to the body, chronic pain, phantom breast pain, decreased strength, anxiety, depression, and fatigue. There are so many more physical and emotional side effects depending on person to person. In conclusion, there is an importance on monthly self-breast exams, seeing your PCP yearly for early detection. There's no cure, but there is proper treatment and management. Mammograms should be happening every 2 years for women age 40 to 50 and annually for women age 53 to 70. And most importantly, going through a disease like cancer requires love and support from families and friends. These are all the references that I used. And my project was peer-reviewed by Valerie Hernandez. And these are all the references for the images that I used and the slides that they're located on. Thank you so much.